Kia ora koutou, everybody. Welcome to our October online Q&A session with Look Good, Feel Better. My name is Rachel Utamapu and I am happy to be coming to you today from the mostly sunny Taranaki, New Plymouth area. Now, it's wonderful to have you all on board, and I hope wherever you are in the country, you've got some nice sun shining in your windows and it's not too cold. Thank you for coming along today. We've got a really exciting speaker that's going to be sharing some wonderful insights with us today. Just before we get started, though, we'll do a little bit of housekeeping. We'd like you all to be on mute, and I see most of you are on mute already, which is absolutely wonderful. It makes it easier for everybody to be able to hear our speaker if we're able to be on mute. If you'd like to ask some questions, because we would really appreciate your feedback and some questions along the way, you can use the chat box for that, and then we'll be able to ask those questions to our speaker afterwards. So what we're going to do is our speaker will talk for around about 40 minutes, and then after that we're going to be able to go to our Q&A session where you can have some feedback and ask some questions, and then we can have a wonderful conversation. So I'd like to introduce the wonderful Victoria Thompson. Now, in this session, Victoria will share information about bowel cancer. She will talk about Bowel Cancer New Zealand, the support available for patients in whānau, and general information about bowel cancer, and most often asked questions about treatment. Victoria is an experienced registered nurse and sees her role as an amazing opportunity to help patients in whānau through nursing support, education and advice, and to increase the awareness of bowel cancer. With an extensive background in community palliative care, Victoria is a people person who loves helping others. She is warm and approachable and easy to talk to. She says she's only ever had the best patients and families. Now, if you've been diagnosed with bowel cancer or someone you love has been, don't be afraid to reach out for support. This is the advice that she offers. I can point you in the right direction, help you figure out all that confusing bowel cancer terminology and the effects of different treatments, and even be able to help you work out what to say to your family. What I'd also like to say is that Victoria has just done a marathon today. So she's coming to us. She's just run the Auckland Marathon, and now she's going to come and share her wonderful insights. So wonderful to have you along, Victoria. Thank you so much. And I'd like to hand it over to you.
Oh, lovely. Thank you. Thank you so much. It was the half marathon that I did today. I don't think I could have done 42 kilometres if my will probably would, but my body just would not have taken that. But thank you so much for the very kind invitation to come and have a chat with everybody. I am based up here in Auckland, and at the moment we're just waiting for the storm to hit, and it is very windy outside, but we're okay for the moment. It's not freezing cold, so we're good to go. So as Rachel said, I'm going to have a chat with you about a little bit about bowel cancer, where we sit, kind of some of the stats and figures, some of the things that we can be looking for and things like that. I'll also talk to you a little bit about our charity, and where we kind of fit into the landscape as far as bowel cancer goes. And I'm more than happy to answer questions either as they come through or towards the end. So please have them ready. I want to make this as interactive as we can. So if we can just go to the first slide. And there it is. So, bowel cancer, where do we sit? So, there's around about 3,400 people that are diagnosed with bowel cancer every year. That's a reasonable amount of people. And there's somewhere in and around 1,300 that are going to die from it each year. Now, if you look at that number, it's actually around about the same as prostate and breast combined, which is pretty significant. And the biggest change over the last few decades has been the fact that there's more and more young people being diagnosed, and it's now around about 1 in 10 people are under 50. So that, kind of takes into account a lot of our mums and dads, with young families and young children out there. So it is something that we're keeping an eye on and that we really need to be, kind of looking into. Māori and Pacifica are often diagnosed at a much younger age and a much more advanced stage. And there's probably a few reasons for why that might happen. Partly a little bit of it is just to do around the whole kind of not wanting to talk too much about what's actually going on within their bodies and things like that. And also some pretty big stigmas. And we do have the National Bowel Screening Program, which is for those aged 60 to 74 years old. It finally had its full rollout in June last year. Took a wee while. Waitemata was the pilot project, and which has been going for quite a number of years. So it has taken a wee while for that to get going, but it is New Zealand wide now. So if we can put the next slide. There we go. So again, just a little bit of some numbers for you. So this is from an organisation, the Binational Colorectal Cancer Audit. It's a registry of bowel cancer patients that covers both Australia and New Zealand. And the one thing that we found with our statistics between the two countries is that they're incredibly similar per head of population. So it's interesting to see stats like, the average age at diagnosis for men and women is in that late 60s age group. However, more and more young people are being diagnosed with bowel cancer, and they're often diagnosed with more rectal cancers. And it's, like I said before, it's about 1 in 10 now. So if we can go to the next slide. So earlier this year, we ran a bit of an awareness campaign called Get Off Your Butt. We do like butts. There's a lot of those in a lot of our work that we do. And we asked patients to, give us an idea of the kind of symptoms that they were experiencing before they went to their doctors, and kind of found out which ones were at the top. And the one thing that we found that was really consistent throughout was the biggest thing that took patients to their GPs was a change in their bowel habits. So you need to know what's normal for you and then figure out what's not normal. So it's more frequent, less frequent. It's things like consistency, shape, smell, and things like that. Interestingly enough, bleeding from the bottom was one of the lesser of them that actually took people to their doctors. And that may be because often people will put bleeding down to other things, whether that's hemorrhoids, whether that's, they've been a little bit constipated or something like that. Or sometimes it's such a small amount that people don't often notice it. So it was interesting to see what it is that actually takes us to our doctors, to kind of get checked out. So next slide. So for our younger patients, what we're starting to hear is that they may well have no initial symptoms, and it can often be found a little bit incidentally. So someone was having some scans for something that was wrong with their back, and the radiographer noticed something a little bit suspicious when they were looking at the scans, and yet this person really didn't have any symptoms at all. So it's interesting that our younger people often don't have the same sort of symptom picture as our older people do. For our older people, a lot of it is centered around a positive fit result. So those are your National Screening Program kits. It does have some really cool words. It's a fecal fecal hemoglobin that shows up. So that's kind of where a lot of the diagnoses in that late onset bowel cancer actually coming from. And then the kind of the change in bowel habits and the lethargy, that tiredness that comes on where, not even rest is actually going to kind of help it out. So there are some differences when we're looking at those that are of a younger age group to those that are within that kind of screening age group. So if we can go to the next slide. So let's go all the way back then. And what is bowel cancer? Starting from the top. It normally starts as just a growth, a polyp. They're a little bit like a skin tag on the inside of your bowel. These can develop into cancer if they're left untreated. They can be anywhere at all along the colon. So your colon starts at your appendix and goes all the way through to your anus. It's around about 1.5 to 2 meters long. So there's a reasonable amount of tubing to it. And it generally will take anywhere between 5 and 10 years for a polyp to develop. And then it can take a little bit longer than that to become cancerous if it's going to. So on our next slide, I've actually got a few pictures for you. I hope that you're not all kind of eating too much at the moment. So up at the top, you have what we call a normal colon. It's nice and pink, it's nice and clean, and there's nothing kind of mysterious or anything poking out that we're looking for. Next to that, we have something called a sessile polyp. Now, these can be quite flat to the surface of the bowel and can be quite difficult to pick up. They can be any size as well. They can kind of range from around about a sort of a grain of rice size right the way through to quite a bit bigger than that. The next one down has got the best word ever. It's a pedunculated polyp, which are kind of cool. They look a little bit like mushrooms. They can grow up to sort of 3 or 4 centimeters. So that's pretty big when you consider how big the inside of your colon is. And then down the bottom, we've got a growing tumor. So that's one that we don't want to be finding. And you can see how something like that growing in your bowel would be changing the way your bowel habits work. Things would get stuck behind it. It would change the shape of your bowel motions and things like that as it's trying to get past. So that's what we don't want to be seeing when we're having colonoscopies done, but that's what they can look like at a slightly more advanced stage. Next slide, please. So some of your risk factors, there's some things that there's very little that we can do about. We can't do much about our age. We also can't do much about our family history, but we do need to be aware of it. Another risk factor for bowel cancer is any sort of inflammatory bowel condition. So those are things like ulcerative colitis, diverticulitis, Crohn's disease, those kind of things where your bowel is already upset can lead to changes which then can turn into a bowel cancer. There's also increasing environmental risks, our diet, exercise, the more sedentary your lifestyle, the slower your gut tends to work, and then the more likely you can be to develop kind of bowel cancers as well as other health risks. Alcohol has been linked to bowel cancer. That higher end of an alcohol intake, and of course stress. Not much we can do about that either some days. However, it is something that tends to upset our guts. Having just done the half marathon, I was as nervous as anything beforehand, and just that increased stress, the kind of risks that tends to have on your bowels. There are genetic risks as well. Most common of the genetic ones is called Lynch syndrome. which is a syndrome that causes polyps to develop much more quickly and to turn much more quickly into bowel cancer. Now, Lynch syndrome is also associated with a lot of the other pelvic cancers, ovarian, and uterine, things like that, as well as other gastric ones like stomach. So it can turn up in different places in your body, but it is one of the big genetic ones. The other one is the familial adenopatous polyps, which is basically where you get multiple polyps developing along the bowel. Now, when we say multiple, we're talking 30, 40, 50, 100. And these need to be removed, and they grow so quickly that people often have to have colonoscopies yearly to make sure that those are gotten rid of each time. There's also the risk that if you've had a family member who was diagnosed under the age of 55, that tends to increase your risk. Whereas if they're in that little bit older age group, your risk tends to remain fairly much the same as anyone else within the population. And then, of course, any other previous gastro cancers in your stomach, small intestine, any of those other ones, all within the pelvis. So next slide, please. The good news is that if it's caught early, bowel cancer is well over 90% treatable and beatable. So when it's caught at those early stages, stage 1, stage 2, it can be treated and people can go on to live a normal lifespan. This is where the screening program and having screening available is so imperative. The earlier we can catch bowel cancer, the easier it is to treat, the less surgery, the less chemo, and the less interventions we need to have done. So next slide, please. So how do we treat bowel cancer in New Zealand? What have we got available to us in our arsenal? Next slide. For the most part, it will depend on what stage your bowel cancer was when it was found as to what options are going to be looked at. For those early ones, it's often just surgery, and then that is given the all clear and people can go on with their lives. A little bit later, some of them will often need radiation therapy. That's often the rectal and anal cancers will often have radiotherapy as the first line, the first thing that actually happens. There's chemotherapy that a lot of us are aware of. And then there's these new immune or targeted therapies, which have are coming onto the health market more and more as we go. So next slide, please. There we go. So yeah, like I say, for those early stages, you can look at just surgery. They will take out the tumour, they'll take out a little bit of the surrounding tissue to make sure that they've got nice, what they call clear edges. They'll also look at some of the lymph nodes just to make sure that there's nothing else involved. You may have some what they call adjuvant chemotherapy, which is kind of alongside, and that's to mop up any remaining cells. That can be in those later stage 2 cancers. They may just look at doing some what they call mop-up chemo. Once it gets to stage 3 and 4, they'll often involve a mixture of all of the modalities that we have available to us. But that requires a really thorough assessment and often a good discussion within the multidisciplinary team. So next slide, please. So these are the chemotherapy drugs that are funded for bowel cancer within New Zealand. Now, I'm only going to do the short abbreviated names because I'm not very good at the really long ones. I'm not an oncology nurse, so they don't roll off the tongue like they do for some other people. So we've got things like Folfox, we've got Capox, we've got Folfox Fury, We have 5-FU alone and capecitabine alone. Now, those are our first-line chemos, and those are the ones that are most often used if there aren't specific mutations in the tumour. These can work incredibly effectively, even for stage 4 cancers, because not all stage 4 cancers need those new drugs coming on. They do all have side effects. Oxaliplatin and capecitabine are notorious for giving peripheral neuropathy. And so, there's need to be aware of that. I suppose one bonus to a lot of the bowel cancer chemotherapy drugs is, though, that most of the patients that I've spoken to don't tend to lose their hair, or certainly not all of it. They may have some thinning, or, it kind of gets a little bit more brittle, but a lot of the patients still maintain and keep most of their hair, which, believe me, is a huge bonus for a lot of people. So the next slide, please. So targeted therapies. These are the new drugs that are coming on. They're aimed at specific genes or proteins within tumours. They're designed to kind of get your immune system ready so that it can recognise and kill the cancer cells. So they're there to kind of give your immune system a bit of a hyper boost, and give it a bit of Superman powers. They're mainly used in New Zealand as treatment for metastatic cancer, so they're not first-line treatments, generally speaking, and they're most often not used for the stage 3 cancers. It's usually only stage 4. They can be used in and of themselves, or they can be used with the capecitabine or some of the other chemotherapies. However, they are not funded in New Zealand currently. These are all out of pocket for the person, and that needs to be taken into consideration when they're being prescribed for anybody. So next slide, please. So the main ones that are used within New Zealand, again, I will apologise, I will use the slightly easier versions of the names. Avastin, cetuximab, Keytruda, and Stivarga. Keytruda is funded for melanoma and for lung cancer, and it can be really good for bowel cancer patients who do have those lung secondaries. So all of these are used in conjunction with various mutations that may be found when they're examining bowel cancer tumours. There's certain BRAF and CRAS mutations that will favour one of these medications over another one. Some of the considerations, though, that you need to take whenever anyone's going to be looking into any of the immune therapies or targeted therapies is that some of them will have a cap on the cost of the drug, which is amazing. Things like Keytruda will have once you've spent a certain amount on the actual drug, it no longer costs you after that. But one thing to take into consideration is the fact that because they have to be delivered via the private system, there is an administration cost that is ongoing when you're going to be having these drugs. And that will keep going for as long as you have them. Now, different places will charge different things, and some insurances will cover some of that cost. So it's always a good idea to have those conversations with your oncologist if that's something that's actually going to be worthwhile and worth looking into for you. So next slide, please. Okay, here we go. What's new and upcoming in the world of bowel cancer? Ooh, all the excitement coming together all at once. So next slide, please. So there has been a change to the National Bowel Screening Program. We now have a slow rollout of a lowering of the age for Māori and Pacifica. If you're in the Waikato, you can get screening done from 50 for Māori and Pacifica, and that will be rolled out throughout New Zealand over the next 12 months. We did have pledges from both of the leaders, and now that comes down to Christopher Luxton, to lower the screening ages for all people, in line with what's happening over in Australia. It'll be interesting to see how that pans out in the next little while. And I don't know if any of you have noticed, but there's been quite a lot of media attention on bowel cancer recently, on screening options and treatments available, and how New Zealand has got quite a gap as far as some medicines go for some treatments. So there's been a lot of attention on bowel cancer recently. That may be because there's some reasonably high profile people coming through at the moment and sharing their stories. Di Henwood would be a really, really good example of that, coming forward and being really open and really honest about his journey and his story as he's going through treatment at the moment. So there is a lot more being talked about out there. And we'd like to think here at Bowel Cancer New Zealand, we've had a little bit of a role in that. So next slide, please. Some of the upcoming things within this circle. I recently had the amazing opportunity to go to the New Zealand Oncology Society conference, and some of the research that is going into colorectal cancer is just mind-blowing. There's some very clever people out there. There's research going into our gut microbiome, all of the flora and fauna that sits within our gut. How does that play a role in bowel cancer? Is there a certain element of that biome, if it's there or not there, that makes you more or less prevalent to it? It's really interesting. You may have heard about the canine sniffer dogs. They're so cute. They are down in Dunedin, doing really well at the moment. And so they're actually using urine samples and getting the dogs to try and pick up whether or not they can actually detect bowel cancer within that, which is kind of exciting. The dogs are actually showing some really good potential. It's still a wee way off being open to the public, but just knowing that it's there is actually kind of cool. There's also work around kind of blood tests for colorectal cancer with circulating DNA. And the reason for this is that, generally speaking, bowel cancer won't show up in a blood test. There are some tests that can be done that may point the way. One of them is having your iron levels done, because if they're low, it can often show that there's a slow bleed somewhere. But other markers that are used in other cancers often don't show any change at all within bowel cancer. So they're looking at whether or not they can actually find ways to find the circulating tumour DNA at the moment. They're also looking at the kind of the difference in the microbial things for early onset bowel cancer. And there's also about to be, I'd like a drum roll, but I can't really do one at the moment. There is about to be launched within New Zealand an advanced home test that can actually pick up certain specific cancer cells from a stool sample, which is really exciting. And I'm hoping, like anything, that I'll have more news about that before the end of this year. It will be one that people need to pay for, but it will be able to be accessed through GPs and things like that. And it's really good because New Zealand doesn't have anything available if you're outside of the screening age. So it'll be great to have that self-home test available again. Next slide, please. So who are we? Where do we fit into the landscape of things out there at the moment? Next slide. So the charity was started back in 2010 by a group of patients and there and some carers who recognised that there was kind of nothing really out there and no one advocating for bowel cancer patients, and working to kind of raise that awareness. So this charity was started by people who had been through it, and who had survived or they'd cared for somebody. So our focus is to raise awareness, to do education, to advocate, to put money into research. And the biggest part of what we do, and it's always been the biggest part of our mandate, is to support. It's that Kiwis helping Kiwis. It's us getting alongside. And we want to make sure that, the impact of bowel cancer in New Zealand is, just reduced. It'd be wonderful to have it eliminated because it is, an incredibly, good one to kind of be able to beat and treat. Next slide, please. So some of the services that we have free physiotherapy. We do this with Pink and Steel, who are our joint organisation that help with that, and we will fund up to 3 sessions for that. We also have counselling for patients and their immediate carer. What we've found is that families and carers need support, because if they fall down, patients tend to fall down. So we want to make sure that the whānau is supported as much as we can. Last year, we started our financial assistance. These are just one-off vouchers that we are able to give for patients for either groceries or petrol, and it's a really cool thing to be able to do. We've got online support groups on Facebook, and currently we have around about 1,600 members in all of our support groups. They are an amazing wealth of peer-to-peer knowledge and information and just really good support. Once a month, I also have a virtual coffee group, which is always hilarious, and it's very much a case of what's said in Vegas stays in Vegas. There's very few things that are off limits in our coffee group. At certain times of the year, we also put on webinars and panels that are specific for bowel cancer. In June, we had Chris Wakeling come in to do a webinar on Lynch syndrome. We've had private only ones for just our members as well on a whole raft of subjects: sleeping during treatment, medicinal cannabis, kind of how to look after yourself. So they're really topical to what it is that our patients are actually wanting. There's me as the nurse support. I'm at the end of the phone. I'm via email. We have a little chat on our website. And we also have a range of resources which is growing all the time. Anything from eating well during treatment right the way through to survivorship, fact sheets on how you can do fundraising for some of your other things as well. So there's a lot of information within our website. Thank you very much, bowelcancernz.org.nz. Heaps of stuff on there if you're wanting to have a look. So next slide, please. So as mentioned, we are very much around awareness, getting the word out there. We have a couple of really big campaigns. Next month, we start our Never Too Young campaign, which is for GPs and the general public, about just being aware that bowel cancer, like most cancers, actually doesn't have an age restriction on it. Education, I have the absolute pleasure of being able to do education out to community groups, into corporate worlds, GP conferences, which was incredibly scary. Doing peer-to-peer conferences is always interesting. Advocacy, we will continue to push for the screening age to come down for all New Zealanders, as well as research, and making sure that there's money going into specific research to help bowel cancer patients. Next slide, please. So our three main campaigns are our Never Too Young, which, like I said, will be going next month. We have Get Off Your Butt, which is very much an awareness campaign around symptoms and not sitting on your symptoms. And then hopefully at least some of you have heard about Move Your Butt, which is our challenge that we have running each year, where you can get up and do a little bit of exercise and get some fundraising and do all sorts of things. We had one guy that decided he was going to do 100 burpees every day. I don't know why either, but that was his challenge, and he did it with his wife. And we had other people that were getting out and doing all sorts of amazing things. It was incredibly cool. So next slide, please. So this is us. This is our team. There we have built up to 7. We have 2 full-timers, and the rest of us all work part-time. We have Rebecca, who's our general manager and tries to keep us all in line. Mary, who does our campaigns managing and communications. Myself. Jo Morgan, she is incredibly good. She does a lot of our grants applications and is just amazing at being able to work with all of those providers. Odessa does our accounts, our finances. She is the person I go to when I get completely stuck and don't know how to fix my spreadsheet. And she is often one of the first ports of call that people will actually come to. Sheena has recently joined our team as part of our long-term giving and bequests program. She comes from an extensive hospice background and is just starting to kind of look into the long-term, bit more stable giving. And then Bella, we call her our young'un. She has recently started with us and does a lot of our social media communications, and she also looks after all of our fundraisers. So that's us. We like to say we're a small team with a really big heart. Next slide, please. So here are my details. If any of you would like to get in contact, or if you have family members, one of the easiest ways to get hold of me is via the chat on our website. It pops up every time on all of the pages, and all of those chats come through to me. Although I don't always answer them out of my work hours, I will always get back to people. We also have the 0800 phone number, and you can text me on my mobile as well. I do only work Monday to Thursday, 9 to 4 p.m, but I will get back to anyone just as quickly as I can. So thank you very much. I'm pretty sure that's the end of my presentation. Yay, got it right. So if there are any questions out there, I know that there was one came through via email, which I can get to. But if there's anything else or any other comments that have come through, I'm all yours.
Victoria, thank you so much. That was wonderful. You've got so many insights and so much knowledge in this space. It's just wonderful to listen to you. One of the things that really resonated with me is this Kiwis helping Kiwis and getting alongside each other. And I think, part of our moving forward is being able to embrace each other and support each other along. Out to our audience, have we got any questions that anybody would like to ask Victoria, or anything that you'd like to share with her? No,
you will need to unmute yourself if you do have a question.
Absolutely. Yeah. Victoria, you did have a couple of questions that came in via email. Did you want to address those? Did you want me to read them out, or?
If you could, that would probably. I did have it open on one of my other screens, but then I'm going to lose everything that I'm doing at the moment. Okay.
So a couple of questions here was from someone had come in that had said, what can be done to ease the physical sensations of peripheral neuropathy?
Yeah, this is a big one, and it's something that the bowel cancer chemotherapies are notorious for. Is this neuropathy within your fingers, within your feet, and there can also be this real kind of sensitivity to cold, not being able to pick up a glass of water or kind of touch cold things out of the fridge. I mean, there's medications that you can take that can help with neuropathy. You can talk to your specialist, your GP, about those. There's things like pregabalin, gabapentin, things like that you can take that are medications that you can use for that neuropathy. One of the hacks that's recently come through on our Facebook page is that, and there is some studies that actually back this up, is actually using topical Voltaren. I know. Um, there is, like I say, there is a study out there, a double-blind placebo that has been done, and I know that there's a couple of patients that have actually tried it just recently, and they've found it incredibly helpful for that hands and feet neuropathy. So it might be worth giving it a go. I suppose one of the other things is, exercise can help, just to kind of rebalance your brain as to where your body is in time and space, because particularly that foot neuropathy can be really difficult to know where your feet are exactly. You can end up with all sorts of odd sensations. So doing things like some physiotherapy with specific physiotherapists can be really, really helpful. But it's worth having a chat if you do have it. Have a chat with your treating team or your GP to find out what's actually going to work for you. It could be that you need a combination of things. You may need some of the medications to actually help stop those nerves firing in the first instance, which will actually help that, and then try some of the other things. There's recommendations around using, kind of ice during treatment to try and stop it, but then you've got to weigh that up with the fact that feeling of cold can be quite debilitating. So it's worth playing around with some things to try and find out what's actually going to work best for you. And sometimes something as simple as, because it can keep people awake at night, so sometimes just being able to get good sleep hygiene, and maybe even something that will just take the edge off so that you can get a decent night's sleep, can just make it more
Bearable.
easy to tolerate during the day because you're actually rested. So yeah, there are things that you can do for it.
And so with that, Victoria, also, I guess there's the mental side of it, isn't it? Is that coping? And you've probably answered that a wee bit by saying if you're rested, you've got that ability to be able to cope with it. Is there anything that can, any sort of tips and tricks towards keeping that restlessness?
Um, like I say, sometimes just doing those kind of the gentle exercisey kind of things can actually help, because what it does is it gives the rest of your muscles that are around that something that they can do. So going for a walk will actually kind of give your legs and your body actually something that it can do. It gets you out of the house, out of that mindset, out of that spiral that can happen when we start getting really kind of frustrated with these kind of things. And yet, like I say, sometimes you actually need to get it under control before you can get your brain under control. So sometimes it's actually, getting some medication for it, making it a little bit better, and then once it is feeling a little bit better, then your brain's got time to kind of relax and de-stress itself because it's not as bad as it was.
Okay, thank you. And just one more thing on that, I guess, is timeframes. And we may have a question here. Have we? Have you? Is that Peter wanting to ask a question?
That was my question about peripheral neuropathy. I've I'm probably a good news story of the bowel cancer. Well, for some reason, I had a colonoscopy when I had no real thoughts of having it. I had it, discovered I had bowel cancer, had surgery, had the chemo, and this was all 6 or 7 years ago, and I'm still here, so that's good. But I've got this gift, which I'm pretty sure is now going to be a lifelong gift, the peripheral neuropathy. I know 5 other people that have had similar, that have had that chemotherapy, the oxaliplatin,
Mhm.
and they've all got peripheral neuropathy, and they've all got it, and have had it, for a long time. Um, and what is difficult for me is just the relentlessness of it. I know I'm going to have it for the rest of my life, and it just every now and then I think, oh my God. um, well, I hope I have it for a long more time. I hope my life does go on for a lot longer. But yeah, sometimes there's only one response that I can. There's only one way I can handle it is to revert to profanities
Mm.
and moaning to everybody for a week or so. And yeah, just when I first had it, I had counselling, and the counsellor had said to me, um, TFM, which you've just got it for the moment. Just think of it like that. You've just got it for the moment. And that sort of got me through that sort of initial stages because, well, I might not have it forever, but now I can't use that trick. I've got to find some other trick to,
Yeah.
what's the word? Um, I don't know, just get through those um, spots where it does get to me. It's the relentlessness that is so grind you downy.
Mm.
Yeah. Yeah.
So that's
Peter,
me.
do you take anything for it, Peter?
No, I talked to my GP, and my treatment team doesn't exist. The day I had my last bit of chemo was the last day I saw anybody involved with cancer,
Mm, mm,
specialists. And I did sort of
mm.
wonder if our oncologists really know how big a gift they're giving us with these side effects. I guess they do. Um, and I guess what does it matter when you're still alive? And it seems a bit pathetic, but trivial, I guess, to be thinking, to be not complaining about it, but to be um, regretting it, I guess. Uh,
Mm.
yeah.
Yeah.
No, I
Uh,
haven't had any of my GP says, look, is it stopping you doing anything? It's not. I still do stuff.
mm,
Um,
mm.
and it doesn't affect my sleep. I seem to have developed a trick for not letting it stop my sleep. So I just grin and bear it.
It's hard though, because
Yeah, yeah.
it is a specific type of pain, and pain's exhausting. And it does, as you absolutely said, it grinds away at you. And you might be good for ages, and then it just gets on top of you because there's other stuff going on, and you have those few days where it's just like,
Yeah,
but like
exactly.
watching the rugby this morning where you kind of wanted to take the referee's knees out. But and those are the hard ones. And like I said, it might be worth giving the Voltaren gel a go. Is it your hands
Okay,
or
yeah.
feet that are worse?
Sorry.
Is it your hands or feet that are worse?
No, feet. My hands are okay. It's my feet.
Cool. Cool. It might be worth giving it a go. You've probably got nothing to lose by giving it a go on those days that are really bad. Maybe not using it all the time, because you don't want to be taking and using Voltaren all the time. You don't want that kind of thing in your system, every day of the week. But maybe on those bad days, and when it's really just getting into your head, give it a go, and see if it helps. And yeah, I mean, I've got an amazing lady who just says, well, I just have to live with it now, don't I? And I'm like, yes, you do. And she's like, okay. And off she goes. And she goes out and plays bowls. But that's not an easy, it's not an easy one, because there will be days where it's just awful.
Yeah. Okay. Thank you, Victoria.
You're more than welcome.
Now, we just had a comment here from one of our participants. Is I had bad peripheral neuropathy after chemo for my myeloma. I found regular exercises help, so that's been something that's been really beneficial. So thank you for sharing that with us. And Peter, thank you for sharing. Really neat that we could chat with you about it. Right. I think that just about brings us to the end of our session. I would just like to say, Victoria, a huge thank you to you for coming along and sharing all your insights and your huge amount of knowledge with us. It's been absolutely wonderful. We'll put in the chat, we'll put all the websites and some contact details. So if anybody wants to get hold of Victoria, they can. For our participants out there, lovely to see you all today, and really appreciate you coming along, and I hope you found today's session useful. And look, we look forward to seeing you back online again at our next workshop. So take care, everybody. Have a lovely rest of your Sunday afternoon, and we'll look forward to seeing you all again soon. Ka kite.
Ka kite.